Hi, thank you, Dr. Rabina. And thank you for hosting this meeting. And thank you for i3D for providing wonderful service to our practice and our courses. And the goal of my presentation today is to show how we're using our workflows and define the workflows that we're using in our clinical practice, and also to talk about how i3D can enhance your clinical practice by alleviating some of the heavy lifting when it comes to guide design and fabrication. So, as Dr. Rabina mentioned, um, my wife, Dr. Catherine Ferguson, and I have a private practice in a town called Davie, Florida, but we spend a lot of our time teaching implant courses through our programs with implant educators. Now, our main course is a live surgery program that we run with the University of Florida in a town called Seminole, where they have a teaching facility. So about once a month, we go to this course and we bring dentists from all over the United States and foreign countries as well. We can actually bring any US licensed dentist to this facility and they can place implants and do procedures, including bone grafting surgery, sinus grafting, et cetera, under our supervision. So you don't have to have a Florida license to come to this program. This is our 16th year running the program, and it's something we're very proud of. And we'll talk a little bit more about that later. But this is our lineup of our speakers. Anybody's interested, we haven't put up our 2024 to 2025 course schedule as yet, but we're working on that right now. This is the current lineup of our speakers that we have for this particular year. The course usually runs September through about May. Um, so we run it over the school year, which makes it convenient for folks not interfering with their vacations and such. You can see we have, a variety of different experts in implantology and beyond. And as I mentioned, we have a small private practice in a town called Davie near Fort Lauderdale, Florida, where Dr. Catherine Ferguson and I do clinical dentistry. In this particular practice, we do a lot of 3D printing, and this is our current lineup of 3D printers that we use literally on a daily basis to do every type of procedure in dentistry practically. And I'll mention a little bit about what we're doing with the designs from i3D as well. This is not the future, folks. This is currently available to anybody and at a relatively low cost to enhance your clinical practice. And of course, it all comes down to the patient and the clinical exam and diagnosis, data acquisition, which typically for surgical guides is going to include CBCT, impressions, bite registration. Now, that could be a conventional impression, but most of the time these days we're going to digital scanning. You're going to mount the models in the software. Um, and if you don't have a scanner, you can scan models or send them out to be scanned. Plan cases in the software, design a guide, and typically 3D print a guide. Now, we've been doing this since 2015 in our practice. I got involved doing this because I saw the need for going to the next level with with our implant surgeries. Prior to 2015, we really weren't doing surgical guides. We were doing everything freehand, and we saw the benefit. And that was since 1993, actually, when I got out of dental school and learned implants and started teaching implants. We were really doing everything freehand. But around 2015, we saw the benefits and the accuracy of doing surgical guides and also the efficiency of incorporate that in our clinical practice. And we started adopting 3D printing to make those surgical guides. So it's all about the data sets, knowing which data sets to capture so that you or i3D or another service like them can design surgical guides for you. And I've sort of simplified this. I've developed protocols in our own clinical practice, and which I'm going to share with you now, and I've shared for the last few years, three case types to create surgical guides, and the data sets vary depending on the case type. So a broad overview is that you're going to take a CBCT of the jaw. You're going to do a prosthetic scan if you have a prosthesis already that you want to use to plan the position of the implants. You're going to do an optical scan or impression or a stone model and then scan that. And then you're going to line all of these surfaces, which are brought in as STL surfaces, to the CBCT of the jaw, plan your implants. You're going to draw out your surgical guide. The software will then create the surgical guide and then 3D print. Sounds very simple, but it's actually a little bit more complicated than that because there are settings and things that need to be worked out depending on your implant system, if you're using a guided surgery kit or non-guided surgery kit, if you're doing a pilot guide or fully guided protocol with not just drilling, but placement of the implant as well. To get the most accuracy, you're going to want to use a guided surgery kit that allows you to also not just drill the osteotomy, but place the implant through the guide as well. So these are the case types and our protocols in our clinical practice for how to use these case types. Case type 1 is a dentate patient with 5 or more virgin teeth. The reason we're talking about having virgin teeth is because those show up really well and don't cause a huge amount of X-ray scatter, or what we call beam hardening, on the CBCT image, so we can align that typically with an intraoral scan very easily. Now, if you don't have an intraoral scanner, you can use an impression and then scan that into CBCT to create the defined scan or STL file to align to the CBCT, because the surgical guide is going to be made on that defined scan, not on the CBCT image, which is typically a grayscale image from which a 3D rendering is created. But it can lead to inaccuracies if you're just using that, because the mouth will have typically restorations such as amalgams or metal crowns or zirconia restorations that can interfere with the accuracy of the CBCT image at a localized area, especially at the teeth level. Now, at the bone level, you'll typically be able, if you position the patient properly, to get a clean scan of the bone and the tooth roots. But we're really talking about restorations at the tooth level, which is what we need to align the defined scan, which is an intraoral scan or a scan of an impression or a scan of a stone model. You're going to then do a prosthetic wax up or bring one in if you already have one. Let's say the patient has a denture that's already an adequate fitting denture. Prosthetics are good on it, the function and aesthetics also. You're going to use that then to plan the implant based on the proper prosthetic positions. Again, create and draw out where you want your surgical guide to go, and then the software will spit out your STL file, which you send to a 3D printer to create your guide. A case type 2 is where you have less than 5 virgin teeth. That means that now you have teeth that have significant restorations in them that will create beam hardening artifacts on your CBCT, which will make it difficult to align the intraoral scan to your CBCT image. So the defined scan, I should say. And to get around this in our clinical practice, I came up with a technique to use a VPS impression as your scan appliance. The scan appliance was nothing new, but I found an easy way to create a scan appliance using an impression with fiducial markers, which then you can align to the CBCT of the jaw, because you're taking a scan of the CBCT with that scan appliance in the mouth as well. So 2 scans are done with the CBCT. You don't need an intraoral scan to do a case type 2. You take a CBCT of the scan appliance in the mouth, and then you take a CBCT of the scan appliance by itself, both of which have fiducial markers, which you then use to align. And then from there, the workflow is similar to the case type 1 workflow, except you're going to, if you're using an impression, for example, of your scan appliance, you can invert that in the software. And I'll talk about the software as well, because one of the reasons I really like using i3D is because they use what I think is the most versatile guide fabrication software out there, which is Blue Sky Plan. And there's a workflow in Blue Sky Plan to convert that impression that was scanned in the CBT into a defined positive model that you can then plan your implants on, draw your surgical guide, and then export and 3D print that surgical guide. So our case type 2, to make it very simple in our clinical practice, is we use this rule of 5 or less virgin teeth. The patient has less than 5 virgin teeth. We are going to scan appliance workflow rather than just an intraoral scan and a CBCT of the jaw. And then the case type 3 is a denture guide. Case type 3 is actually the easiest type to plan. You're scanning the patient with the denture in their mouth with fiducial markers attached, and that is basically your scan appliance. Then you're going to scan the denture by itself, again with the fiducial markers attached. And the software workflow in Blue Sky Plan makes it very easy to align the two things together, again using fiducial markers. It now has, it knows the volume and the size of the denture it actually has. It creates an STL file of the denture on which you can use then to plan your implants, and it will convert that denture by one click in the software to create a surgical guide, which you can then 3D print. Now we'll look at the workflow. And then if you take that now to the next level of complexity, where you're talking about bone reduction guides, you can take these same case types, case type 1, and also add more steps where you have to do, for example, a bone segmentation, and you're going to design a guide, fixation pin index guide, a bone reduction guide, drilling guide. More workflows, of course, means more complexity and more things that you have to create. But this is how we're doing all on X bone reduction guides using Blue Sky Plan as well. In the case type 2 with bone reduction, again, same data sets that we're capturing, but we're taking it to the next level with a bone segmentation, because now we have, when we're doing bone reduction guides have to fit on the bone, not just on an intraoral scan. So this is the case type 1, the case type 2 with bone reduction, and then we can also do a case type 3, which is a edentulous patient with bone reduction. Not as simple as doing a case type 3, where we're not doing bone reduction, but same data set capture basically, and then we're doing more complex workflows to get the actual bone reduction guides for an all-on-X type of case. So these steps with the bone reduction guides are the most complicated today, and even though things have been added to the software and there's more, algorithms being put in the software to simplify this, it still takes a long time to design this type of guide. A case type 1 guide, you can knock out with just no bone reduction. You can knock that out in a couple of minutes, 10 minutes, 15 minutes, depending on the number of implants, but certainly for a single tooth guide, once you get proficient at it, it could be as easy as 10 minutes. But these types of bone reduction guides, even for somebody like myself who's well versed in the software and actually teaches other dentists how to do this, it still will take me 2 to 3 hours to design a bone reduction guide. Now, I try not to do it all in one sitting because it can become very tedious. But over a period of several days, I might work on a case and work out different parameters for and types of guides. But it's very time consuming, and this is where a company like i3D can come in and takes some of that load off of the clinical practice and create the guides for you. One thing, again, I mentioned that I like about i3D is that you're using Blue Sky Plan. So making any changes from the plan that you get back from i3D or communication is very easy because they'll send you the Blue Sky Plan, and that way you can make any changes. So I still think even if you're not designing your own guides, there is some value in learning the software. Not necessarily every aspect of it, but at least knowing how to move the implants around so that they can help you. And communication is a lot better. I've worked with other companies where, I wasn't using the software that a company is using to design, and you have to go back and forth so many times to get it right. And this just makes it easier because they can send you the Blue Sky plan or the Blue Sky project, and you can, again, if you have the knowledge and skills to make the few little changes, it's very easy to do. So to simplify it, here's what we do in our clinical practice. We will go in and, of course, see the patient and talk about the case and what the patient's goals are and what we're capable of doing. And then, of course, once the patient accepts the treatment, now we have to capture the data sets. So what we tell our assistants is in a case type 1, they know what to do. They know they're going to take an intraoral scan, normal bite, CBCT with the teeth apart. Case type 2, impression with fiducial markers, and then a CBCT with the impression in the mouth using, again, if the patient has less than 5 virgin teeth. That's, the rule of 5. So case type 3 is where you have a CBCT of the denture with fiducial markers and CBCT of the denture in the mouth, again with the fiducial markers. And so our assistants know, I'll tell them we're doing a case type 1, they know what data sets. Case type 2, they know they're going to do a PVS impression with fiducial markers, etc. And a case type 3, CBCT of the denture with the fiducial markers attached. So they'll take that denture, attach the fiducial markers, take the scan, then scan the denture with the denture in the mouth, patient biting down on the denture, etc. And then, of course, more recently, we have added things such as face scans, and now after the implants were placed, we're doing photogrammetry scans. So this really helps dial things in, especially for your FP3 type cases where you're doing bone reductions and such, and we're doing immediate delivery of a prosthesis right after the implants are placed. These face scans and such really help. And again, I'm showing you this slide because I think training and delegation is the key. I don't do the scans, obviously. Our assistants are doing these, so they need to understand the workflows and especially what data sets. So we train our assistants to know which data sets are required for each type of case, right? Training and delegation is key. You got to get your assistants involved in this stuff because it does make it a lot easier for the clinical practice. So for example, this is a denture based guide, which is a case type 3. You can see how basically the denture is being duplicated to become a surgical guide, one of the simplest workflows, okay? So let's look at a case. This is Kathy, 78 years old. You can see she has some dental needs. And in this particular case, we felt the best treatment for her was to edentulate her. And because of all the bone loss and the alignment of the teeth, et cetera, we're going to edentulate her and do all on X. In this case, we're doing 6 implants on the upper and 5 on the lower to give her a full mouth FP3 type restoration. Now, this is one of the earlier cases we did, and she did have some medical issues, so we decided to stage the case, and we actually edentulated her first, and then let everything heal, and then went back and did the upper as a case type 3, not bone reduction, but actually using the denture-based guide and just drilling through the tissue and placing the implants. So this is a one-click denture guide, case type 3. We had edentulated her, so you could actually convert, your dentate patients into an edentulous case. And sometimes for some of our workflows, it's actually easier to do that. Sometimes the patients need bone grafting in a few areas, and we will put them in a denture to accomplish that. Of course, everybody wants to do immediate load these days, and people are going over to zygoma implants and pterygoid implants and such. But sometimes if the patient's willing to be a little bit patient, you can do it with this type of workflow as well by extracting teeth, doing some bone grafting and such. And we still do a lot of sinus grafting for these types of cases to prepare the patient for a full arch type of restoration. So here are the fiducial markers attached to the denture. In Kathy's case, this is now the denture is brought into the software. We plan out 6 implants. And in this case, we were not going to do immediate load. Um, one of the requirements for this patient was that she didn't want to be in the chair for a very long period of time. So we broke up the treatment into several steps. But I got the chance here to show you the case type 3. So this is the guide that was produced from the case type 3 scans, basically the denture with fiducial markers scanned in the mouth, and then the denture scanned by itself. All of this data is put into the software. Implants are planned out, and this prosthesis is going to give us a prosthetic goal as well. So here is a surgical guide being used. The patient bites it down to place. We drill fixation pins to fixate it to the jaw. And then once it's fixated, in this particular case, we didn't even do any tissue punch, just went right through. It's a very short appointment, about 40 minutes start to finish. Placed our 6 implants. This is immediately after the implants were placed, went right through the tissue, and this is a post-op. Now we are going to do some bone reduction because it's a FP3 type case, but we decided to stage it, let the implants integrate on this patient, and then go back and do the bone reductions at a future date. This is after about 5 months. We used the original surgical guide to locate the position of the implants, and then we just sort of connected the dots, laid a flap, did our bone reduction, and then again, we broke this case up into several steps for the patient, placed healing collars, let that heal, and then went back and placed our multi-unit abutments, and then finished up with our prosthesis. Now, the lower we decided to treat a little bit differently because we had enough teeth there that we could do a case type 1, except we did this as what's called a sequential guide. So because we have the ability to 3D print and make our guides in office at a low cost, we went ahead and did this as a sequential guide, which again, case type 1. But we planned out the first surgical guide for placement of 3 implants, and then we extracted additional teeth. In this case of the design fab of the guides, we actually did digital extractions, which simulate what's going to happen throughout the surgery. So 2 surgical guides, one initially how the patient presented with teeth, and then the second one, we extracted some teeth and then placed a second guide and placed additional implants into those spots where the teeth were extracted. Now, what's nice about this is you can actually fixate the guide to the previously placed implants. So here are the 2 guides that we made, right? They're basically identical, except the second guide just has additional areas, cylinders. We're going to place the additional 2 implants after these teeth that were under the guide here were extracted. So this is how we did it clinically. We placed the guide in, drilled and placed 3 implants. And then after those implants were placed, we then extracted and did some bone reduction. You use a second guide to place the additional 2 implants over here. And then we actually went ahead and placed some healing collars, a PRF membrane around there, and then at a future date uncovered everything and placed multi-unit abutments. And now we're ready for our final restorations upper and lower. So we like to prototype these restorations for a period of time to make sure the patient is comfortable and accepts the aesthetics before we go to final, which we're doing typically in zirconia these days, full monolithic zirconia. So these are 3D printed prostheses that we did a pickup and then characterized with various stains or pink composites. We did upper and lower 3D printed prosthetics, refined the aesthetics and the function for the patient before going to zirconia. So once we have this done, we can scan the implant positions using photogrammetry or off of a stone model and combine that in software such as Exocad and then produce the final zirconia restoration. So what we're doing here is we're going in and placing the scans of the printed prosthesis. The patient wanted a few little changes, so we made those changes in Exocad software and then output these in a zirconia restoration for the patient. This is the upper and lower final monolithic zirconia. And this is what we delivered for the patient, meeting her aesthetic and functional demands. So here's the final patient smile, um, lateral views as well. And that's what we're able to deliver using the case type 3 on the top and the case type 1 on the bottom. So we can combine these case types as well on an individual patient. All right. So this is a case type 2. This is Judy. This is how she presented. And you can see she has a lot of restorations in the upper jaw that were failing. And because of all the metal, we had to do this case as a case type 2. Now, I did publish this in the compendium a few years back, demonstrating how we could do this type of case without any intraoral scan. All of this was done only using CBCT data. So this is a case type 2 with bone reduction. Basically, we're scanning the patient with an impression in the mouth with fiducial markers, and then scanning that impression in the CBCT blue sky plan. We can convert that to an STL file on which we can then create the surgical guides, etc. But we're also doing bone segmentation here and creating a bone reduction guide directly on the bone. So the design process basically follows the surgery. So the first guide we're going to create in this case was the bone reduction guide. And, of course, we have a prosthetic goal in mind. In this case, the patient's pre-existing teeth were the prosthetic goal. And we can then, from that, create bone segmentation, plan out the implants. All of these things are aligned in blue sky plan, and we can create our surgical guide. Here we're doing our bone reduction. And then on top of that, we place a drilling guide, which is based on the model that was created here with the bone reduction guide and the reduced bone model. So here we are placing our implants. We've drilled our osteotomy, we are placing our implants through our guide. And in this case, we did a few years back, we actually did a pickup. So we had a 3D printed prosthesis that was ready to be picked up in the mouth, and we use an injectable resin to pick that up with temporary cylinders. So the cylinders are placed, the prosthesis is placed over the cylinders. Cylinders are typically cut back ahead of time. That can all be planned in the software as well. I do give a course on how to do this workflow, although we don't do this workflow anymore because we're now going direct to 3D printed prosthesis after the implants are placed, direct to multi-unit. So in this, again, here we're doing a pickup. We use a rubber dam to keep the resin from getting locked onto the multi-unit abutments. Once that pickup is done, we'll hand this over to our dental assistant who will finish the prosthesis. In the meantime, we can go ahead and close and do any bone contouring, smoothing of any bone, and do the soft tissue closure. And typically we're using PRF with that. So here is the 3D printed prosthesis picked up in the mouth, finished by our dental assistant while we're finishing the surgery. And then this is screwed into place. And our goal with these prostheses is to not remove them until the implants are integrated and ready to be scanned. The patient's ready to be scanned for the final prosthesis. We sometimes have to go back and make second prototypes because of the patient's aesthetic and cosmetic demands, and also the function. If we find that their functional needs aren't being met, we can make changes to the design and 3D printed prosthesis. But this is actually the same prosthesis some 5 months later. Looks different because of the camera settings that were used. It looks a little wider here, but it's actually the same prosthesis. The patient came in after 5 months. We removed it. And the patient was doing a pretty good job keeping it clean. The implants are all integrated. Multi-unit abutments X-rays were taken to make sure the implants were good. Multi-unit abutments were scanned, and then a new prosthesis was designed and delivered for this patient. This is the final patient prosthesis. From the temporary or the immediately placed prosthesis, we made some cosmetic changes to enhance the patient's smile. And also the patient wanted the teeth to be whiter, so we went with that as well in the final zirconia restoration. Okay. So how accurate are surgical guides? They're as accurate as you want them to be, keeping in mind that, the more expertise you have in this area and the more knowledge you have and the more you are uh, careful about acquiring your data sets, the more accurate your surgical guides can be. So here's a partial extraction therapy case. Now, partial extraction therapy is something that requires extreme precision, but it allows us to do some beautiful, really beautiful work because we're preserving the soft and hard tissues around the implant site. What you see here is the before on tooth number 8, and then the after restoration that was produced to duplicate the patient's anatomy prior to the extraction of the tooth and after the implant is restored. So this was treated as a case type 1, and I also published this in 2022, and it's on the cover of Inside Dentistry. Uh, and the idea here is when you have a patient with high aesthetic demands like this patient, you want to make sure that you do things to the highest level of accuracy, and that's what we're able to do with partial extraction therapy and then guided implant placement as well. So here are the steps in how we did it. We removed the tooth, section off the crown off the tooth. We split the tooth and carefully dissected out, leaving just a shell or a shield, a root shield against the buccal plate. And now we have to precisely place the implant into the site. I'll tell you, it's not something that's very easy to do with freehand surgery, but with guided surgery, it's much simpler to do. And that's how we planned out the case, making sure that we have our root shield, we have a gap between the implant and where the root shield is of 1 to 2 millimeters, and then the implant. So here is how we accomplished it. This was all planned ahead of time. A surgical guide was created and 3D printed, using that to create the osteotomy, but then also place the implant through that osteotomy. And this was the result. You can see the incisive canal here. You can see our root shield in place, that space between the root shield and the implant. And of course, we have our palatal bone here and our incisive foramen. So here is the before, how we planned it out. Okay. And here is the before and after overlaid. So we can actually take overlays of the post-op CVC with actual implant position, overlay, and judge how accurate our implant placement was. This level of accuracy is impossible with freehand surgery, in my opinion. You might get lucky occasionally, but this is why we've adopted surgical guides in such a big way in our clinical practice. So that's the before and after. You can see the root shield here, the implant in white, and then the position, plan position, and when we're planning a surgical guide in red. And because we didn't have the highest implant stability in this case, we decided not to load the implant immediately. So we created a custom healing collar healing abutment, sorry, that we used with a PRF seal to give the patient, not having any changes in the gingival architecture. And then the patient wore a removable prosthesis until the implant integrate. Or you can do a bonded restoration. We're doing some really nice bonded 3D printed restorations now, Maryland bridge type restorations that can last the duration until the implant integrates. Here is immediately after the implant was placed. Here is a week post-op. You can see how nice the tissues are healing. They're nice and healthy. And there's another view. And then after 5 months, we'll remove that customized healing collar and place a temporary and start defining what we want the final restoration to look like. Once we have it close to what we want the final restoration to look like, and we've developed the soft tissue, we can scan that. And in this case, we had a custom abutment milled with a tie base with a zirconia top. And then from there, we also we actually milled this in-house, a Emax crown, which we then custom stained. So this is what the final restoration looks like on a X-ray. And here's the final restoration in the patient's mouth before and after. This is what it looks like on a close-up. You can see how we preserved the gingival architecture. This patient wanted us to actually preserve the exact gingival architecture that she came in with. And we were able to do that and customize the crown to look very close to what actually, I think it looked better than what she started with. We were able to match the adjacent tooth a little bit better as far as the shade. And here is a lateral view as well, close up, and how that harmoniously fit into the patient's dentition. Hard to tell that that's an implant restoration. But this level of accuracy starts with the implant placement, and that's where the surgical guide comes in. So this is a more recent case. This is Marjorie, case type 1. We did orthodontic treatment on this patient. And even though we hadn't finished the orthodontic treatment, the patient put a little bit of pressure on us. This is where we got her with the orthodontic treatment, but she put some pressure on us that she was actually getting married and we needed to finish up the case. Even though the orthodontic treatment wasn't fully completed, I would have liked to move the teeth apart a little bit more, get some more space between the roots before we put implants in. But we looked at the case and thought, and because we're using guided surgery, we decided to go ahead and actually place the implants. This is a case type 1 dentate patient. This is what the blue sky plan looked like. Planned out 2 implants in the existing bone that we had. And you can see we had actually moved the canines apart. And a lot of times when you move canines like that, what you're doing is tipping, not so much bodily movement. We would have preferred to have a little bit more time to do some more bodily movement on the patient. We had used some TADs as well to try to accomplish that. But given the time constraints, we looked and see if we could accomplish it. And we felt comfortable because we're using guided surgery that we can get the level of precision that we needed. So we created the surgical guides and used them to place the implants. And we didn't do immediate load on this case. We actually scanned the implant positions after the surgery, and then had custom abutments and 3D printed prototypes produced. I think we put these in 2 days later. So these are actually custom abutments on the immediately scanned implant positions. We could do this same day, but it'd be a lot of work, especially if we want to go with titanium abutments. In this case, I'm not comfortable putting printed abutments in directly to the implant interface, but this was done with custom abutments and then 3D printed prototype restorations. We did use the Rodin sculpture resin here with my mini plate on the Frozen Sonic Mini 4K. It's got very good detail prints, and we cemented those onto the milled titanium abutments, which we actually milled in office as well. We outsourced the design of the abutments, but we milled it on our in-office Roland 42W mill. So this is what the patient looked like, a few weeks later after she actually came back from her wedding, and you can see it fit in pretty good. And then we'll go from this to final restorations, which are probably going to be Emax or zirconia. We have nice translucent zirconias these days. So we're able to do things in a faster fashion. We're able to do things more efficiently for the patient. We're able to do things that we frankly couldn't do before in dentistry. Squeeze implants into places really where we couldn't before. And if you have an experienced designer that is going to make sure you get the right data sets, such as image 3D conversion, they can guide you on what data sets you're going to need to get the highest level of accuracy. And I think it's important when you communicate with them, you let them know what level of accuracy you're trying to achieve. That way they make sure that they evaluate your data sets so that you are getting that level of accuracy. Sometimes if the scans aren't exactly perfect, if there was a little bit of patient movement or artifacting, you can get away in areas where you have a lot of bone. But in areas like where that last case I just showed you, it requires, or the last two cases, it requires a very high level of precision. So your scans have to be basically perfect. Okay. So I'm going to show you now this last case is a full arch restoration that I actually didn't do the surgery on this one, which is a full arch case where, I'm using image 3D conversion to design the case. And we did this case at the University of Florida Dental Clinic in our course. So this case was done by a team of dentists in the course who most of them had never placed implants before. But because everything was worked out and planned out by i3D, and we actually printed the guides in-house, and all the parts and the restoration as well, we printed that in-house. You'll see how we're able to use their design even though we're doing our own printing. And of course, if you don't have a 3D printer, they can create the guides for you. And they've got nice metal 3D printers now, etc. But in this case, I didn't do the surgery. Our team supervised the surgery, and then we had a team of doctors, about 3 or 4 doctors working on the case together, because this is a somewhat complex case, with but with extractions, bone reduction guides, drilling guide, and then we actually placed the implants, put multi-unit abutments on, did photogrammetry scan, and designed and 3D printed a restoration the same day. So that's the type of thing we're doing in our implant courses today. It's not the future. This is something that we're doing in our clinical practice, and now we can teach this so that more folks can do this, and it eliminates a lot of the confusion. Patients want things immediately, so we can now deliver at least prototypes immediately, and then the patient will wear that for 5 months, and then we can go to the final restorations, right? So the more data sets you have, of course, to merge, the more accurate you can get. And the only thing that's kind of missing from this workflow here is maybe face scan to help that aspect of it, the aesthetic aspect of it as well. And then after the implants are placed, we will do photogrammetry scan of the implant position. So this is sort of the guides that are going to be needed for this type of case. These are the i3D type guides. This is their designs. We're doing immediate loading. So the first thing you want is a positioning guide so that you index using fixation pins, create index holes for your bone reduction guide. The bone reduction guide goes in, you do the bone reduction, and then the implant placement guide is stacked on top of that. And because the bone reduction guides need to be very thin so they're not cumbersome and you can get them into your flap, you can see i3D has gone to printing these in metal. And we're not doing that ourselves, but if you so choose, they can make these in metal for you, which are very, very strong so that they don't break during the surgery. Because if you're printing these out of just regular surgical guide resin, sometimes they'll break. And what we had done in the past is print a couple of these bone reduction guides if we're doing them out of resin. That way, in case we have one fracture or something, we can, we have a backup. Not too challenging because you just just duplicate it on your 3D printer. And then they can make and design a prosthesis with holes in them so that you can do a pickup. Today, we're actually moving to doing a conversion after the implants are placed, merging the actual implant positions with the pre-designed prosthesis and in the software, and then spitting out a 3D printed restoration, which is how we actually did this case, even though they designed a prosthetic like this for us. But it all starts with scanning prior. This was actually scanned as a case type 1 with bone reduction. So maxilla, occlusion, and the lower arch as well. Digital planning. So in this case, what I told them where I wanted the implants to be placed. They designed the case, sent it to me. as a blue sky project, and then I tweaked a couple of little positions, sent it back to them, and they finalized and created the surgical guides, bone reduction guide, drilling guides. This is what it looks like. They sent these files back to me because we're going to 3D print in house. Again, they can make these for you, but we did this case where we 3D printed everything in house. So these files were sent back to us again with the blue sky plan. Here's the pin guide. That's the first guide we're going to use. Then we do the bone reduction guide, osteotomy guide, and of course we did 3D print a temporary prosthesis just in case. And actually, in this particular case, all of the guides and as well as the prototype immediately load restoration was printed on our current workhorse printer, which is the Frozen Sonic Mini 8KS, which in the US you can buy on Amazon for about $300. Of course, I have made some additional parts for it to increase the reliability and speed. I have a mini plate that fits on this, which I sell, and then also a vat warmer. So it brings the price up to about $1,000 for everything. And you can get some really highly detailed prints on this. This printer will print XY resolution of 22 microns. And what's really nice about this printer is the Z axis, the height and the build platform moving up and down is extremely accurate. I've run tests on it compared to other of these types of printers I've used in the past, even some very expensive ones. And the accuracy of the Z axis just makes this, takes it to the next level. So Rodan Titan is, to me, the best resin out there for doing full arch restorations today. We're still using these as prototypes, but I've actually left some of these types of full arch printed restorations in for several years on some patients, and they've held up pretty good. Not this particular one for several years. This has only been out for, I believe, like maybe 8 months or so, or maybe less. But these are holding up very well, and this is currently, I think, the strongest and very aesthetic as well that we can use for 3D printed restorations. Will these become final restorations in the future? I think we still need more data on that, but certainly they can be used as long-term interims. And the beauty of it is we can print these in about an hour on this printer, less than an hour actually, and deliver it to the patient same day. So this is how we proceeded with the case. We put the pin fixation guide in, drilled, and placed that in. We actually had 4 pins in this case, right? Then we removed that, laid a flap, used those pin fixation holes to index our bone reduction guide. Now, as I said earlier, in the past, these bone reduction guides would sometimes break on us because they're fairly thin. The thicker you make them, the more cumbersome they are to use in the surgery. So again, that's why i3D has gone to doing metal printing. Metal printers are very expensive, and probably most of, we're not going to probably be using that in our clinical offices. So unless you have a large group practice, it's probably not worth it to get in metal 3D printing. But what I found is actually with this Rodan Titan, because it is such a strong resin, it does give you the ability to print these bone reduction guides. Not as strong as metal, but certainly much stronger than regular surgical guide resin. So in this case, it wasn't designed for bone reduction guides, but I used a Titan resin to print the bone reduction guide in this case, and it worked really well. It was really strong and rigid, and that's what we did. So we extracted the teeth, did the bone reduction using this Rodan Titan 3D printed surgical guide and our bone reduction guide, did the bone reduction. Then on top of that, we snapped in the surgical guide, which was printed out of surgical guide resin that was designed also by i3D to fit into these slots. And then there are these pins, which typically are metal, that fit and hold that into place. I actually 3D printed these in Rodan Titan as well. So you have your fixation pins, and then the surgical guide snaps in to these open slots here, and then a pin fits into that, which again I 3D printed. That holds everything together. the drilling guide is then used to drill and place our implants. So here's the implants are actually placed. Here's one implant placed in the posterior. The two distal implants are angled 45 degrees. And here are the additional implants placed with the surgical guide. And these are the carriers. We'll remove the carriers and then take off the surgical guides. Once that's done, before we even took out the bone reduction guide, we have access to the tops of the implants. We place our multi-unit abutments. And we did use the micron mapper photogrammetry unit to scan the implant positions. And then from that, we could merge that data with the pre-op prosthetic design. And while that is being converted in the software to 3D print a restoration to these multi-units directly, we will go ahead and close up the case and suture. And for that, we'll typically put cover caps on the multi-unit abutments. And then once the prosthesis is printed, we'll remove those and screw it into place. And the fit on these we found to be really, really good. So in this case, not necessarily most aesthetic. Understand that this was done by students, time constraints and such. When you're doing this in your clinical practice, you can probably spend a little bit more time characterizing and making it look better. But this case, the patient went home with a prosthesis, teeth in a day. They got a prosthesis to go home, and that's going to stay in for 4 or 5 months. And we're going to then take that out and do the final restoration. So that's the patient's smile. Patient is, of course, numb, so they're not smiling very broadly, but that's a patient's smile. The patient left the clinic. And of course, we don't really need to see these patients up for a quick post-op visit a week or so later, and then monthly follow-ups. And in about 4 or 5 months, we can take this prosthesis out and go to a final restoration. Okay. So with that, I will take any questions. And before I do that, I want to thank i3D again for hosting this meeting, and thank them for their surgical guide designs. And the idea of us being able to free up some of my time, certainly, because I'm the one typically doing a lot of the planning of these surgical guides in our clinical practice, to take some of that heavy lifting off of us. Depending on your volume, you might want to do your simple surgical guides, but certainly for the more complex ones, I teach courses on how to do them. I think it is valuable to take a course on how to do them and to understand all the steps, because it makes you a better clinician, makes you a better surgeon when you know what went into the process. And also if you need to troubleshoot things, or also to be able to evaluate the designs that you get back from a company like i3D and make sure that things are accurate. Okay. So with that, again, thank you, i3D.